Thank you for joining us for another edition of the top 5 things you need to know from the AUA meeting. My name is Max Cates. I'm director of the Division of Urologic Oncology at the Brady Urological Institute at Johns Hopkins. And with me today is Dr. Arvin George, who leads the prostate cancer program here at the Brady. And I'm very excited to hear about the top 5 things you need to know from the AUA meeting in prostate cancer. So Arvin, take it away. What do we need to know?
Great. Thanks, Max. I'd say that, AUA is so full of different updates and in prostate cancer and many other categories. I think that 5 is pretty limiting. You'll see a theme here when I talk about the different studies that I'm going to mention today, or the key points that I thought will change my practice. And a lot of it has to do with improvements in our imaging and how our imaging, specifically PSMA PET, can impact our management. So the first thing, if I look at PSMA, is understanding what do we see on PSMA PET at different PSA levels. So historically, every single time, in the post-treatment setting, we rely almost exclusively on PSMA. Not on PSMA, on PSA rather, for us to be able to identify or risk stratify those men who are ultimately going to experience recurrence, and starts with biochemical recurrence. But that biochemical recurrence does not tell us if it's distant or localized disease, or where exactly disease is. And so we really need to understand the performance characteristics of PSMA PET as we start to obtain it earlier and earlier and earlier in that post-treatment setting. Additionally, I think that there was a great study that looked at the impact of lutetium PSMA on different, which is a theranostic modality going into the advanced prostate cancer space, looking at how does it perform based on the location of the metastasis, specifically in bony metastasis versus lymph node metastasis, which can have a different biology of their disease and consequently potentially different treatment responses. And then remaining in the advanced prostate cancer space is the role of metastasis-directed therapy. As we learn more and more about prostate cancer, I think our indications in terms of who we categorize as oligometastatic has changed, and we're starting to understand the role of cytoreduction, tumor debulking, whatever you want to call it in the prostate cancer setting. And then finally, I'll say that this is probably 6 rather than 5. 2 things that I'd like to touch on are going to be the role of telemedicine in prostate cancer specifically. And we all know that we're coming off of the pandemic. Our telemedicine has increased significantly. However, coming post-pandemic, we're starting to recalibrate and identify the strengths and weaknesses of telemedicine. And it's important how we can utilize that in prostate cancer, specifically maintaining access to those who may most need it, specifically underrepresented minorities and different socioeconomic groups. And then finally, the historic transrectal transperineal debate. I'm not sure today that we'll have a final conclusion or answer to it, but hopefully we'll be able to talk through some of the data that exists and how that it can impact your practice.
That's really fantastic. Let's kind of go in order of diagnosing prostate cancer and down that way. So let's jump right in with the first thing you need to know from the AUA in prostate cancer, which is that the debate around transperineal versus transrectal guided biopsy of the prostate has not been decided. This is a very interesting history. I think even 5 years ago, very few American urologists were performing a lot of transperineal biopsies. And now it sounds like the tide is really shifting. And we're starting to gather some evidence. Can you kind of give us a little bit of a short history of sort of TP versus TR and sort of where we stand now with the evidence?
Sure. As we all know, the reason that we really started to move towards transperineal biopsy has been a continued problem with infectious hospitalizations, post-prostate biopsy infections that have over time been increasing largely as a result of increasing fluoroquinolone resistance, or just antimicrobial resistance in general. I'd say that, we are victims of our own practice in that our common solution has been throwing more antibiotics at the problem. And even the most recent AUA antimicrobial prophylaxis best practice statement, which was updated a couple years ago, now advocates for augmented prophylaxis. So essentially, rather than giving a fluoroquinolone alone, adding a fluoroquinolone or third-generation cephalosporin plus an aminoglycoside. So our contemporary solutions have been add more antibiotics to the problem, but in my opinion, we're just going to return to where we have historically been in that we're going to continue to drive resistance. And a simple procedural modification, I say simple, there is a learning curve that's associated with it, but the ability to sample the prostate transperineally has basically gotten out of the area which is most likely to seed the prostate or bloodstream and cause a bacteremia by going transperineal. It's by no means perfect, but I'll say it's pretty close to it from an infectious hospitalization standpoint. Now, where does the data stand currently? So there have been two probably major trials that have focused on the infection component of it. There have been previously randomized controlled trials in TP versus TR, really powered more towards cancer detection. And that really isn't much of a question anymore. I would say that if you're taking the same amount of samples from a transperineal biopsy versus a transrectal biopsy, your cancer detection rates are largely equivalent outside of some very specific settings, anterior tumors, etc. Now, when we look at the two most recent trials, which are the PROBE-PC trial and the PREVENT trial, which was an updated analysis was presented by Jim Hugh at the AUA, that updated analysis showed us a little bit different than what we've seen historically with those two contemporary trials. The PROBE-PC trial was a single institutional series from Albany, which showed actually no difference in a composite endpoint of different infectious complications between transrectal and transperineal. Important to note that transrectal got antibiotics and transperineal largely did not get antibiotics. And to me, that's a critical difference because the success of transperineal biopsy is not really only the reduction in infection rates, but it's really our ability to eliminate antibiotics altogether and significantly reduce antimicrobial resistance. About almost 2 million prostate biopsies are performed in the US alone every year. You can imagine how much antibiotics that's going to prevent entering into the community.
I had a mentor that once told me that there are some trials where non-inferiority is superiority. And that's kind
right.
of what that's basically what you're saying with this whole debate is that, well, if one group is flooding our urology practices with antimicrobials and the other group is not, and they're equivalent, then one would think we're going to reduce resistance over time by eliminating antibiotics. So that's fascinating. So the debate is ongoing, but there was some interesting data presented at the AUA. Let's now move on to, I think, something that all urologists listening to this have experienced, which is the number two thing you need to know, which is the role of telemedicine is evolving for prostate cancer and potentially reducing disparities. Now, many of us, there were early adopters, certainly, that were doing telemedicine before COVID, but myself and probably most of my colleagues listening really probably took it on during the pandemic. And in many ways, many people have kept it on. And I want to hear from you sort of how you personally view telemedicine, but then what data was presented around it at the AUA.
Yeah, thanks. I think that, telemedicine has become like a real and enduring part of my practice. But that's varying since post-pandemic. I think that we are slowly going back to where we were pre-pandemic, which is increasing the number of face-to-face visits. I still utilize it pretty significantly in my practice. And it was, what I'd like to talk about specifically was a study that was reported by Dr. Khalid Al-Khatib, who's at UPenn. It was a cross-sectional analysis of the National Health Interview Survey from 2020 to 2021, and really looking at two specific questions. Do they have a cancer diagnosis, specifically prostate cancer, and do they engage in virtual care? And if they do we see differences by ethnicity or racial groups And really what we saw was that non-Hispanic Blacks have less telemedicine utilization. Now, there can be many, many different reasons for that, but I think that it's really important for us to evaluate this in its context and understand that there are real concerns outside of, outside of race, but socioeconomic status, the ability to travel, the ability to be able to take time off of work. Some of these cancer diagnoses can be particularly intensive in terms of follow-up. High-risk prostate cancer, surveillance requiring multiple appointments during a year, imaging appointments, PSA blood testing, appointments with the physician. That can be really difficult. Doing telemedicine for people who don't speak English well. I think that we all bias ourselves towards bringing those patients face to face to eliminate communication barriers because it may be harder to get a translator on your telemedicine call. So access to reliable internet may be relevant to some people. Specialty access to care where in rural areas. So I think telemedicine needs to remain a focus, and we really need to make sure that insurance and reimbursement for these telemedicine visits actually align with the care that we're delivering, and it actually remains, so that we're not financially disincentivized to not provide access to these services to all populations, much less those who are most vulnerable.
That's fantastic. And I think, it'll be interesting to see now that we're hopefully in this post-pandemic period, how we're going to realign. All of us are going to make those decisions about what makes sense in person versus telemedicine, what reduces disparities, what improves care. I'm pleased to see research being presented on the topic. So the numbers 3 to 5 things you need to know about prostate cancer. I think, you went where the puck is and where it's going, and that's this real evolution in imaging in the form of PSMA. And it started out with identifying metastatic disease, and now we're really going a step further and trying to interpret it, what it means, how we can use it, and how it can improve our outcomes with our prostate cancer patients. And I think 3 of the topics that you picked with PSMAs really speak to that. So let's really just get started with, how does PSMA perform across varied PSA levels? And what is the research presented at the AUA sort of tell us about that topic?
Yeah, so the study that I'd like to talk about, I think represents kind of a foundational knowledge base type study that anybody who's managing prostate cancer needs to understand, and that's why I included it here. It was presented by Dr. Maya Ataya from Indiana University, looking at the results of PSMA PET scans performed across various PSA thresholds in the post-treatment setting, either after surgery, after radiation, or after both. So to me, I think that there were a few very, very specific take-homes here. So after, most relevant to urologists would be that if you have a detectable PSA post-op between essentially 0 to 0.2, I know many of us use ultrasensitive PSA in this setting, 28% of these are positive post-radical prostatectomy. That's more than a quarter of these patients will have a positive finding on PSMA. Now, PSMA is a bit of a tricky test because, historically, we've been using conventional imaging staging with bone scan and CT. And if we see something positive there, that's considered bulky metastatic disease. If we don't see anything there and it's positive on PSMA PET, essentially we should consider it microscopic disease. So that's important to understand. Now, 0.2 is what we consider biochemical recurrence in the post-prostatectomy setting. So if you have a PSA between 0.2 and 0.5, almost 44% of those patients will have a positive PSMA imaging, essentially having either locally or distant disease. Where a lot of us, we tend to say, hey, well, let's keep watching this PSA. It's rising slowly. Let's see what's happening. When you go to 0.5 to 1, 63% of those men who've had a prostatectomy will have a positive PSMA. And 58% of men who've had prior radiation will have a positive PSMA. So it's important to note that PSMA PET is actually very sensitive even at very low levels of PSA. that we don't want to ignore biochemical recurrence or delay any investigation, because there is a high likelihood we will find something on the PSMA PET. And if we don't, that's informative as well. Oftentimes in this setting, the use of ADT, because it can suppress your PSA, should actually lower your threshold values for testing. And they did find that high-risk prostate cancer defined as grade group 4 or greater and seminal vesicle invasion were predictors of a subsequent positive PSMA PET. So bottom line, take-home message is that even at very low levels, we can find something and we have the opportunity to intervene and potentially still deliver a curative result in that setting.
Yeah, that's fantastic. So this sounds like a glass half full take on using PSMA and the rationale, honestly, for using PSMA post prostatectomy when there is any detectable PSA. I mean, 26% is high enough that I think there is a rationale there, and I know it's still controversial. But let's look at the other side of this, which is this other study that was specifically addressing whether we should be offering localized therapy for patients with N1 disease or on PSMA. And so this speaks to the accuracy of PSMA and whether it should change our management. What did we learn about from that at the AUA?
Yeah, so we have found that PSMA is very sensitive at very low levels. That means that you find a positive result. Now, the question is that how many of those positive results are actually false positives? Now, if we find it, oftentimes we just, as a knee-jerk reaction, we say this person has a mildly positive node in an expected landing zone, external iliac, whatever it is, and we say this person has metastatic disease. They're going to be better served with radiation, where they'll get ADT, and we'll play a supporting role. But I think what we're starting to understand more and more is that the more aggressive the disease is, the more the role there is for multimodal therapy. And so rather than writing off surgery, there was a study recently, the study that was reported at the AUA, that really it was not necessarily a specific study, but it was a session that looked at what is the role of metastasis, metastasis-directed therapy. How often is it when it's actually positive on PSMA? How often are those actually false positives? So this study was by Dr. Francesco Barletta from was 10 different institutions, a multi-institutional study of men who underwent a PSMA PET which had N1 disease, but they still underwent a prostatectomy with an extended lymph node dissection. So within that population of men, they were able to identify, was that N1 disease true or not? So about 48%, or 88 of the patients, they had a total of 130 patients, 48% were N0 at the time of prostatectomy. So that can speak to two different scenarios. One is maybe they missed the node or wasn't read on pathology. But I think that's less likely in this specific setting, where we are going to be very, very focused on identifying that disease if it exists, because we have a signal that it potentially does. But almost 50% of patients who have a positive PSMA scan in the nodes, or N1, they're actually negative at the time of prostatectomy. So what does this ultimately tell us is that we should still consider offering local therapy for patients who have presumed microscopic N1 disease on PSMA PET because of the high level of false positives. And, I think still this lower level SUV uptake remains really a challenge in treatment decision-making. Is this considered metastatic disease? Is it not? How do we treat those patients? I think that if it's within the landing zone where you feel that you can adequately resect it, we should still be offering these patients local therapy with a curative intent.
That's fantastic. And this is clearly an area that a clinical trial is going to be essential to help determine some of these answers, and perhaps trials where we think about neoadjuvant therapies as well, to sort of mitigate the false positive, false negative question here. So let's move on to the fifth and final thing you need to know. And this, once again, is PSMA. And that's the question of, can PSMA determine metastasis directed therapy? Can it guide us in these difficult decisions about whether we can treat metastases and impact our survival outcomes. What did we learn at the AUA regarding this?
Yeah, so we have, metastasis can occur at, multiple different, any site, visceral organs, bony places, nodal, and where they metastasize can potentially have an impact on their outcomes. And so, Max, I just want to make sure, are you asking me about the theranostic study? I just want to make sure that,
Yep.
Okay. Yeah. Okay. Yeah. So, there is a huge promise of theranostics. The ability to both diagnose and treat is really, really huge. And we see this with lutetium PSMA, and we're more and more starting to see what the role of lutetium PSMA is and in what setting. So the study that I wanted to highlight was a study by Dr. Ahmed Mahmood, which looked at almost 300 patients, 273 patients who had both bone and lymph node metastasis. And 76 of those had only bone or only lymph node metastasis, and tried to measure what their treatment response was by looking at repeat imaging with the SUV max, and also the presence of any radiographic progression. So what they did find was that those patients who had nodal only metastasis, they actually did better and had a more durable response versus bone metastasis. So I think it's it's helping us to understand both the role of these promising theranostic treatments, but also understand where they may have limited benefit, and we should really focus our efforts on different treatments. So I think that we still have a lot to learn about lutetium PSMA and these new theranostic modalities. There's a tremendous amount of promise here. There was even a trial on that was presented at the AUA that was a neoadjuvant lutetium PSMA for high-risk prostate cancer prior to prostatectomy, where they get 2 doses 6 weeks apart, repeat imaging at 11 weeks, and then subsequent prostatectomy, which I think will also be a very interesting study to understand what the local response is.
That's fantastic. So this was a great conversation. I feel like I learned a ton about prostate cancer at the AUA, and I hope our listeners did too. Thank you for joining us for another edition of the top 5 things you need to know from the AUA, and stay on the lookout for other similar editions in other disease spaces.